to the demo.
This was really good. This is Frida. Frida is 72 years old and she tripped over a carpet and broke her leg. She was brought to the emergency ward and a young attending physician did the pre-operative examination and found out that there was a faint murmur. Now, the anesthesiologist saw the patient and ordered an echo. We did an echo and this is the study. Look at the short axis view and now at the 4 or 5 chamber view. Does this ring a bell? Well, it should, because we already presented this pathology in one of our first lectures. Here's a short summary.
Yes, when we were talking about aortic valve stenosis, we were imaging the heart from a parasternal long axis view, which cuts the heart, now you know very well, somewhere here through the aortic valve. And we used also the parasternal short axis view at the base, where the aortic valve is always in the middle of our view.
I promise I'm going to solve the case that we just saw, but first I want to go to a patient because you need to find out more about the pathology we'll be talking about.
And here we have an 85-year-old woman who came for dyspnea and after a systolic murmur was detected. And we want to do echo to see what's the real problem.
So this is a little bit of an atypical parasternal long axis view. She's actually not so easy to image, a frequent problem in elderly patients.
But still, we can immediately detect the problem. It stays in the aortic valve.
Right, so the question will be, is this really her problem? Does she have aortic stenosis? So the degree of calcification will be important to look at.
And the valve is calcified, but still the cusps open.
Yeah, I think so too. There's some opening of the cusps, very difficult to see, but I will go to a short axis view. And I think you can appreciate that there is some motion of the aortic valve here. I'll maybe use the zoom view just so that you get a better feeling for the valve. Yeah, but honestly, I would not rely too much on just a 2D image to quantify aortic stenosis, but one thing is clear, I would expect at least some degree of aortic stenosis. Do you agree?
Yes.
Okay, and I think this is the first very important finding in this patient. Don't you see very similar features between the patient we just saw and the one I presented as the first case in this lecture? Well, maybe the patient has aortic stenosis. Now, this obviously puts the whole case into a different perspective. So, possibly she didn't trip, but she had a syncope, and that was the reason she actually broke her leg. And it also puts the risk of surgery in a completely different perspective. Because with aortic stenosis, patients are at greater risk during surgery, especially if they were operated during an emergency procedure or if they have severe symptomatic aortic stenosis. Well, Giovanni Battista Venturi, an Italian physicist, taught us a few very important laws on hemodynamics which help us to assess aortic stenosis. He taught us that if you have a narrowing somewhere along this tube here, you will also have flow acceleration. And we know that this flow acceleration can be measured with echocardiography. I'm sure many of you have experienced this yourself. For example, if you go rafting. A narrowing of the river leads to an acceleration of the flow of water and therefore turbulences. Now, this still doesn't tell us how we can get to the degree of aortic stenosis. To understand that, we first have to use an equation which was created by Bernoulli, the so-called Bernoulli equation, to tell us what the relationship between the velocity and the degree of stenosis is. Now, you will not have to remember this equation, of course. We use a very simplified version of it, which simply is velocity squared times 4, which gives you the gradient between the stenosis before and after the stenosis. Now, this still leaves one question open. How do we measure blood flow velocity in the first place? Well, Christian Doppler taught us that. He was an Austrian physicist and he observed the stars and was able to detect the velocity with which the stars travel simply by looking at the change of color, which is created by a Doppler shift. Now, this is the method we use in echocardiography. Christian Doppler was an Austrian, Bernoulli was an Italian, and here we have the same connection as in this course. Anna and Bruno are Italian and I'm Austrian. In the imaging primer, we already showed you spectral Doppler, where we are able to trace the velocity over time, similar to the way it is done, for example, in trucks, where we track the velocity over time on this little disc. The tracings we use in echocardiography look a little bit different. Now we can measure the velocity across the different valves. For example, here we would have the signal of mitral inflow. This is mitral regurgitation. Here we have tricuspid regurgitation, and this is aortic stenosis. But all of these spectrums have a few common traits. They have a zero line. They have a velocity scale. They have a time scale and a tracing which either points upwards, as in this case of mitral inflow, or downwards, as here in tricuspid regurgitation. So what does the signal tell us that we have in our patient? Well, we have a velocity which moves down or away from the transducer. That's why it is negative. And we have a certain velocity which is somewhere in the region of maybe almost 6 meters here. And we see that we are imaging now from a 5-chamber view, which means this has to be the velocity jet that goes in this direction, away from the valve. So this is the signal of aortic stenosis. Good. Now, what does the signal tell us? Let's go back to this schematic here. This is the stenosis we have. The velocity we measured was 6 meters. All we now need to do is plug it into this formula, and we'll do this right away. We have 4 times 6 squared, okay? That would be 4 times 36, which equals 144, okay? So the gradient we get is 144 millimeters of mercury. Simple, isn't it? What we just got was the maximal gradient. But there's another gradient you need to know, the so-called mean gradient. To get that, you take the curve and you simply trace it. Okay, so you would trace the curve here and thereby get what we call a mean velocity. And then you just take this mean velocity, just as you did the maximum velocity, plug it into the formula, and you will end up with the so-called mean gradient. Now, in reality, you will not need to do that because the system or the machines, they do that all by themselves. But I just want to show it to you so that you understand what is happening and how you actually arrive with the values you see on the machine. Based on these gradients, you then quantify the severity of aortic stenosis. If the mean gradient is below 25 millimeters of mercury, you would call aortic stenosis mild. Between 25 and 40, it's moderate, and above 40 millimeters of mercury, severe. You can also grade via the maximum velocity, but beware that there might be discrepancies. So you should usually rely more on the mean gradients than on the maximum velocity or the maximal gradients. But measuring gradients is only one side of the story. It's also important to know how to obtain a very good signal. And this we're going to show you right now.
So our patient is 85 years old, has a suspicion of aortic stenosis, but we want to know the degree of the stenosis. So what are the next steps?
Right, I would not rely only on the morphology. I would rely more on the continuous wave Doppler that we place through the aortic valve. And we do that in a 5-chamber view, ideally, so that we are better oriented to the flow of blood through the stenotic valve, so that the septum is usually slanted a little bit the way you have it in our view right here. And then you put the continuous wave Doppler through, and then you would simply just trace the curve. And at that time, you would not only get the mean gradient, but also the maximal gradient. So here we are, we have a stenosis which is somewhere in the range of moderate to severe. The mean gradient is 40 millimeters of mercury. The maximal gradient is somewhere in the range of almost 60 millimeters of mercury. So this certainly could be her problem. When it comes to aortic stenosis, what are we really afraid of? A few things. First of all, pressure overload, because this can eventually lead to heart failure. Low cardiac output. In other words, if the stenosis is so tight that no blood goes through, well, especially during exercise, patients can develop syncope. And then finally, patients with aortic stenosis are at increased risk of developing arrhythmias, atrial fibrillation, and even more so, they can develop sudden cardiac death. Well, this is what you don't want to have. a 92-year-old patient with severe aortic stenosis and poor left ventricle function. Well, it turned out that she had triple vessel disease, and we tried to intervene. Unfortunately, the patient died. So you run into all sorts of problems if you have aortic stenosis. And there's a lot of concomitant problems involved in these patients because they're frequently very old. So what should we do now with our patient who is in the emergency ward with a broken leg? Well, her operative risk is certainly elevated. She has a high risk of mortality, of major cardiovascular events, especially if she's symptomatic. Nevertheless, the risk, as I would say, is acceptable, and we did perform orthopedic surgery. Everything went fine, and now she's expecting to have aortic valve replacement by a percutaneous approach, the so-called TAVI. So far, we focused more on the morphology of the aortic valve and how to grade the severity of aortic stenosis. Now I would like to focus on the secondary findings you will see in patients with aortic stenosis. They are equally important. What are they? First of all, left ventricular hypertrophy. Second of all, enlargement of the left atrium. Wall motion abnormalities, you can't see one here. And a dilatation of the ascending aorta. Here's a patient with a wall motion abnormality. You see right up here, this part of the ventricle does not contract normally. This patient, as a matter of fact, also has dysynchrony. And here we have a concomitant problem, mitral regurgitation. You see that there is aortic stenosis here, the valve is calcified, and in addition, it is a regurgitant jet. Why? Because the patient has concomitant mitral annular calcification. Again, patients with aortic stenosis are frequently very old, and therefore they have multiple problems. Here's an example of a patient with a very, very large ascending aorta, an aneurysm, measures almost 6 centimeters. Important to know because if you want to operate on the aortic valve, you might as well replace the ascending aorta as well. Why do you frequently see a dilated aorta in these patients? Well, you remember from the first chapters, because bicuspid valves lead to aortic stenosis, but also to dilatation of the ascending aorta. For all of you who work in a critical care setting, what are the things you have to be aware of? Well, first of all, you will frequently see aortic stenosis. And second of all, remember they have a lot of comorbidities and they are usually very complicated cases. For those who work in a normal echo lab or in a cardiology ward, what should you consider here? Well, you need to closely follow up patients with aortic stenosis because once they are symptomatic and once left ventricular function starts to fail, you have to operate them. So look out for the echo, look out for left ventricular function, and check for symptoms. At the end of this chapter, I want to give you some very personal tips and tricks. The first is you have to perform a continuous wave Doppler in all patients. Not only these where you suspect aortic stenosis, because in some patients the aortic valve might not be calcified, but it can still be stenotic. The second very important fact is take your time. Measuring the aortic valve velocities can be very cumbersome and very difficult in some patients. And if you take your time, I'm sure you will get the maximal gradient, and this is the gradient that you will be using for your quantification. And finally, always put your measurements in context. It just simply does not work to have severe aortic stenosis and no left ventricular hypertrophy. So all the different parameters have to fit together in some way or other. This concludes our chapter on aortic stenosis. Wasn't so difficult, was it? Of course, there are some issues which are much more complex. But for now, I think you have all the information to assess your patients. If you want to go further, yes, we invite you to go to the masterclass.